Let me check whether we are coming. It should go. I think it should go. Yes, I think we are live now. Yeah, it has picked up. Yes, we are live. So, namaste everyone, and I hope we have you here. And today is a very important day. I would not say important, but it's a very fortunate day for us that we are doing live stream with Dr. Haney Mallemet from Philadelphia, USA, and in a short while he will be here. We'll be adding him, and then he will be answering some of the very important questions which are asked by everyone who is working in the intensive care unit or emergency, because everybody has to ventilate and intubate the patients, and this is something area where which agent to give, which neuromuscular to, everybody has lot of questions. So without wasting time, uh, I just want to tell you, you all can post your comments in the comment section, and then we'll take your comments either during the session or during the end. We'll go through each and every comment. So make sure you post in the comment section. So, okay, he's here. So, namaste, Dr. Haney. So nice to see you
How you
here.
doing?
So nice to, and very,
Oh,
very thankful to you that you spare the time in your busy hours and agree to do a session on this very difficult and important topic. So we
no, the
just a
pleasure is
brief.
mine. I love your channel. I love your audience. And when I saw you on Instagram, I started following everything that you've done. You're truly an amazing educator, and the honor is mine to be on your show today. Thank you for having me.
Thank you, thank you. Just a little bit about you. Can you introduce yourself to our audience, which are viewing right now? Just a little brief info about you.
Yeah, my name is Haney Mallemet. I'm an intensivist as well as an emergency medicine physician, and I work in South Jersey, Philadelphia. And my passions are really resuscitation, the use of ultrasound in critical care, but really just anything resuscitation and critical care. I just love talking about it. And I also love teaching. I consider myself an educator and love to put education on all the social media platforms. So I think we have a lot in common in that.
Thank you, thank you. So you have lots of comments pouring in, which are saying thank you and welcome on the channel. So what we'll do now? So we'll start by some basic questionnaire, and then we'll discuss those things. And in between, I'm seeing the comments here. What are the, if the comments are relevant, which we are discussing, we'll take them during the session. If not, we'll take in the end of the session. So to all the audience who are listening, uh, Dr. Haney Mallemet runs a channel on Instagram, which is Critical Care Now, also on the YouTube, and he is passionate about resuscitation. So we have a website. What do you call, Doctor? What is the website name?
Well, we have two websites. The first one is ResusX. That's our
Okay.
conference website. We do conferences throughout the year, and then we have other educational stuff. And we're relaunching our educational website, our free website called criticalcarenow.com, which is
Okay.
going to be, it's live now, but we're relaunching it in a month or two. So we're excited
Thank,
about that. So
thank you.
thanks for the promotion.
No, no, it's not promotion. It's for the everybody's benefit. So the first to start with, I'll start with the basic questionnaire. What is rapid sequence intubation? Basically, there is an intubation which is done in the operation theater OT in the control environment, and there is a rapid sequence intubations. So what things changes in rapid sequence intubation? Because in the intensive care unit, usually the patient is not in a very stable condition. So can you explain about rapid sequence intubation to those who are very new to this field?
What anesthesiologists do before an elective case is they'll sit down with the patient, they'll take a very thorough history, they'll ask to evaluate the airway, they'll see if there's any allergies, and then they get the person to the theater, they take their time, they look at hemodynamics, and in a very controlled setting, an airway will be established and anesthesia will be given. We don't live in that world of control. Our world is defined by out of control. So whether you're in the emergency room or the ICU or going to a response on the floor, we have to rapidly intubate patients in any condition that we're met with. And that's the essence of rapid sequence intubation. It's the establishment of an airway in a critically ill or crashing patient. And then we could talk about some of the nuances of how to properly do that after that.
Okay. So to make it simple, to the newest one, rapid sequence intubation means you have to intubate a patient very rapidly. You don't have a pre-assessment before while intubating the patient. The patient is not hemodynamically stable, and you just want to save the life of the patient as well as take care that the patient doesn't crash just because of the airway management procedure. That's very, very important. So that's the whole crux of this today's topic, that what agents we should use, that at least if we can maximize the hemodynamic stability and facilitate intubation during an unstable environment. So that's the idea. So we know that we don't have an ideal agent for every scenario in particular, but ideally what should be an ideal agent, if we are wished, then what should be an ideal agent during RSI?
Well, for me, there's like two agents that we have to talk about. The first would be the agent that's going to sedate the patient, and the next agent would be a paralytic agent. But if we're looking at all agents taken collectively, what would be the best qualities of an agent? They should be rapidly acting. We should be able to give the medication, and within 1 minute, we should be able to get our maximum effect of that medication. We should have one that's hemodynamically stable because, as you mentioned, we're going to have patients who are already maybe unstable hemodynamically, and many of the medications that we give have vasodilatory properties. The last thing you want to do is make the person more unstable with the actions that you're doing. And then we'd like a medication that would allow us to get those optimal conditions for a very brief time while we're doing the intubation, but also wash off very quickly so we get the person back to their neurologic status baseline, and everything just washes away. So to me, that if I was in a lab creating a medication, or I was asking someone to make a medication, those would be the things that I would be asking for.
Okay, so again, to simplify, just if in case the accent is not very much audible or understandable to everyone, I'm just simplifying. That's the means that's the way we do on the channel what you have discussed. So what Dr. Haney is saying, that two agents, one is sedating the patient and one is relaxing the patient. So two properties very important. The agent which is sedating the patient should make sure that the blood pressure hemodynamics should not compromise. Secondly, the paralytic agent should be fast enough to get recover, because if it remain paralyzed for a longer period of time, the patient will not be able to breathe in case there happens a difficult intubation. So that's two properties which we are looking for, and we'll try to figure out these properties in the coming agents which we are discussing. So first we will be discussing the sedative agents, induction agents, and in the later part we'll be discussing on neuromuscular blockade agents. So my first question is, can we enumerate or list down what are the common agents which we use in different intensive care units, and then we'll discuss one by one the pros and cons of each and every one, and
I'm
then
going to
we'll
list
share,
them in
sorry, then we'll discuss
please.
experience from here, this part of the world also.
Yeah, there may be differences in local hospital cultures, and of course, different countries have access to some different medications. Here in the States, for me and for my colleagues that we discussed this, in order of the best medication to medications we don't really use, it's very simple. For me, I like to use a drug like ketamine for my sedative hypnotic agent. And we can discuss a little bit more about the dosing and whatnot. But I like that because it has the most hemodynamic stability, it's rapidly acting, and it's also quick off. So if I need a neuro exam on my patient afterwards, it has washed off. The next agent down for me would be something like Etomidate. Etomidate also is a good agent because it's rapid on. It has good amnesia to the event. The only reason why it's not a little bit higher up on the list is because there's more data now that's coming out that's saying that it causes some adrenal insufficiency.
Okay.
It used to be that the data was kind of like, maybe it does, maybe it doesn't. It seems like there's more mounting evidence with adrenal insufficiency. So if you have a patient who's in septic shock or has sepsis, you wouldn't want to suppress their cortisol production. So for me, that's an agent that goes a little bit lower on the list. The next agent down for me after that, although I don't use it frequently, would be something like a Versed type of agent, or midazolam, I should use the generic name. And then finally, an agent that I never use, but I hear it in the conversation, would be something like propofol.
Yes. Yes, thank you. So this is a very good startup for all those who are listening. So what is given preference is hemodynamic stability. The agent which don't compromise your blood pressure during intubation is given the preference most. So what sir has told that if ketamine is on the list because contrary to hypotension, it raises the blood pressure a little bit much, so gives you a little bit more benefit during intubation. But if that's the only thing, it should be a radial agent. We'll see why it is not. Second is etomidate. We discuss about adrenaline suppression means the patient, you will intubate the patient, but over the next period of 24 to 48 hours the blood pressure will not pick up even on the vasopressors or inotropes because of the adrenal insufficiency. That's the risk, I think, is with etomidate. Third is benzodiazepines, midazolam in particular. And fourth is propofol, which is used in a very specific condition, not in hemodynamically unstable, because it causes a fall. So I think first we'll discuss the agents and then we discuss the condition wise preferences where we will use which one. So first we'll start with ketamine. So what are the good things about ketamine? What are the bad things about ketamine? Why it's not ideal if it's bringing the BP up in this particular scenario?
To me, there's really no downsides to ketamine except for the doses that you use. Just because there's some people that may have heard these myths, I want to address them right now. It used to be believed that ketamine would increase your intracranial pressure, and so you wouldn't want to use it on someone who is head injured. That is not the case, and there's literature to show that. It used to be thought if you had somebody who had intraocular pressure, you should not use it. Also found to be not reliable. For people who are already tachycardic or hypertensive, you don't want to use it for them. Those people pre-intubation who are tachycardic and hypertensive, those effects are likely because they're in stress, and that's the reason why they have those vital signs. By giving ketamine, you can actually make those vital signs better. So it's not a contraindication to vital signs to give it to them. The downside of ketamine that I found is that if you have a person who is very ill, and we can use shock index as an example of that. And shock index is your heart rate divided by your systolic blood pressure. A person who is having a shock index of greater than 0.8 or 0.9, if you give them the full dose of ketamine, which in the books is 2 milligrams per kilogram, you can actually drop their blood pressure. You can actually cause some hypotension with that. So I found for people like that, the doses must be reduced. Maybe you'll go 0.5 milligrams per kilogram for your induction dose, or all the way up to 1 milligram per kilogram. So I'll stop there because I've said a lot, but for me that's the big summary about ketamine.
That's fantastic. So already the moment we said ketamine, there are comments in the comment section like this, which Dr. Prashant Patel just asked that we had said that ketamine can increase ICP, and so Dr. Haney has just clarified it that it is it doesn't, literature is not showing that much evidence. Earlier it was a vague sort of evidence that it may cause raised ICP, it may cause raised intraocular pressure, but those were the stable patients, other thing, not the one which we are intubating in the RSI. Secondly, the dosing is very important. If you give the full dose, it may make the patient fall in the blood pressure, but the dose which sir has recommended, like 0.5 to 1 milligram per kg body weight, that's the dose you should use. So it will be pretty safe enough to give in this particular scenario. So ketamine is still very top on the list if we see all the agents. It's the only agent which increases the blood pressure a little bit. My question, sir, uh, whether it will be a good for because I'm seeing the comments for neuro patient and cardiac patient both.
I've not seen any literature that says that it wouldn't be used for those reasons.
Okay.
The cardiac patient, I think sometimes people are worried again about the blood pressure and the heart rate, but in fact, it does not increase that. It still is hemodynamically stable for those people. And again, I can't think of any literature that shows that. I work in a very busy academic hospital, and we use that for most of our intubations, and there's never that contraindication to not use it for a certain patient.
Thank you. So I hope this clarifies regarding the ketamine. Now we move on to our second agent on the list is etomidate. So etomidase is supposed to be preferred in cardiac patients, which this is the general consensus that it is a good drug to be used in cardiac patients. So what's your say? What's the benefit and means lacuna of this etomidate? Why it is second on the list for ketamine?
The only reason is the adrenal suppression for me. I think it's a great drug. It can give you a little bit more hypotension in the full dose as compared to ketamine, but I still think it's a very good drug. And if there's anyone that's there that has a concern about the cardiac patient or the neuro patient, essentially someone who doesn't have sepsis or concern for adrenal insufficiency, I say use it. Use it as your first line agent. It's a very good agent, has very good reliability. It has a very quick onset and a quick offset. So it's really an ideal agent.
So regarding this adrenal insufficiency, one of the query is whether why not give etomidate and give 100 milligrams of hydrocortisone in every patient. Is a good practice or should we avoid it?
It's a practice I've seen done, but I would say we don't know if that makes a difference. In other words, you could do that because it just makes sense to you, but there's a lot of things in medicine that make sense that when we do the studies, we find out it doesn't matter. So I would say if you know your person is septic and you know the person is going to have some degree of adrenal insufficiency, don't make that worse by giving another drug. You have an alternative agent. So until that study is done, I can't definitively say whether or not that practice is actually a good practice or not.
Okay, so this highlights a very important point that in a septic patient in which already there is a adrenal insufficiency, if you have to choose between ketamine and etomidate, ketamine takes a upper hand because there is no adrenal insufficiency, and etomidate because it has a adrenal insufficiency side effect. We never know how much dose of steroid, how much dose of this steroid will help to counter that thing. 100 milligrams of hydrocortisone, we never know whether it's working or not working. It's just a psychological benefit that we are giving it. So in septic patients, it is given. So now I think that's all about ketamine and etomidate. Now the third agent, which is very much used in this part of the world for some reason, which is benzodiazepine, specifically midazolam, and it's again used in combination with fentanyl. We'll come to that, but benzodiazepine is used. They may reduce the dose, but it is used. So your take on that?
It's not something I use, and it's mostly because it's just not rapid enough. If we're talking about rapid sequence intubation, I want to push the medication, and then I want to see within a minute of the person being fully dissociated or sedated. And for me, it just takes too long. It also falls into the practice of we're trying to get out of using benzodiazepines in our general ICU practice as a whole for the delirium risk. Now, I don't think that one dose of midazolam is going to cause delirium for the person in the hospital, but the reason why I prefer not to use it is because of the speed of its activity. I have better agents that work faster and more reliable. If for whatever reason we run out of all the ketamine and all the etomidate in the hospital and they need to intubate somebody, I would use it knowing those limitations.
So the point here is two things. One, obviously, benzodiazepine causes a fall in blood pressure. Secondly, more important than that is it takes time, at least 3-4 minutes to act, and you have to wait for that much period of time. You must have experienced in your clinical practice that benzodiazepine midas takes times to act, and you are always in the fear that this may cause a fall in blood pressure also, and it's taking time. Another thing regarding benzodiazepine is midas is you need to reduce the dose also while intubating. You never know what's the dose which is good enough for this particular patient. Now, before coming to propofol, just want to ask that with ketamine, with etomidate, and with benzodiazepine, An opioid, is it required to be given with ketamine, etomidate, or benzodiazepines, or these agents are plain enough, are sufficient to for taking care part of this amnesia or this pain-free intubation?
That's a great question. For ketamine, the dose of analgesia that we normally use for ketamine is zero point 0.3 milligrams per kilogram. So if I'm giving somebody zero point 0.5 or higher, then there's some inherent analgesic property within that induction dose that I'm using for sedation. So I don't think there's any added benefit of doing it. For etomidate, using co-induction with an analgesic like fentanyl, I think is fine. I don't see any problem with it. Um, and then when you get to Versed, again, because it takes so long to act, I'm not sure if it's the fentanyl that's working or the Versed is working. But giving some analgesia as your part of your induction package is not a bad idea. But you do have to be careful that that medication that you're giving also may have vasodilatory properties as well. And so if you have a person who's already hypotensive, your induction agent's causing some hypotension, and your analgesic, even fentanyl, which seems to be hemodynamically stable, that can also have some vasodilatory properties as well. So the more things you add, the more negative side effects you're going to have as well.
Okay. So it depends on your patient condition, clinical scenario. If the patient is a borderline 80s, 90s systolic blood pressure, then go prefer only a single agent like ketamine or etomidate. But etomidate again, avoid in sepsis. But if your blood pressure is giving you a little bit of margin, somewhere systolic is 100, 110, you can then add an analgesia like fentanyl. So it will be make patient little bit more comfortable. I think that's the whole point. Now coming to again the fourth agent which you have told that you have not been a fan of, not being used preferably, but it is being used especially in the neuro patient I have seen is for a neuroprotective role is propofol. So how propofol finds its way in these induction agents?
It's again not one that I use at all because it is so vasodilatory that the person, look, when you have a person who's very sick, we should also talk about this too. When you have a person in front of you who's sick, before you make the decision to intubate them, they may be a little bit hypertensive, they may be a little bit tachycardic, they may be normotensive, but the vital signs that you're seeing in front of you, that is the result of their sympathetic system. That's not their real vital signs. When we push those medications, we take away all that sympathetic drive. It's like the truth serum. We see what their vital signs actually are. And so I say all of this because it's important. When you give somebody propofol, you're taking away that sympathetic drive and you're also causing vasodilatation. You can have a severe drop in your blood pressure. So if you have to use propofol, if you absolutely insist on using it, you have to make a dose adjustment for it. Because propofol is so lipophilic and crosses the blood-brain barrier so quickly, we can give a much lower dose of it because, again, we want it on first pass to the target organ, to the brain, to get us our sedative hypnotic properties. So 10% of the dose that you would use in a normal adult would be the dose that I would use for somebody that I'm intubating. And somebody who is critically ill, who you're about to intubate, that small dose, which might be as little as 1 cc, and you're saying, that's such a small dose, how is this going to produce amnesia in this person? For a person that's sick, that's what you would use. But again, I would not use that medication, even at that small dose, because it's just so unpredictable for me, and I have much better agents.
This is a very, very important point. I think those who have missed, I am repeating it. What Dr. Haney has told that the vital signs which you are seeing while intubating this patient, suppose it's systolic blood pressure over 90s or 100, it is not the actual systolic pressure. It is a systolic pressure which is being compensated by the sympathetic drive, and the body is trying to push hard to make the systolic pressure up to that mark. And the moment you give an agent like propofol or any agent, that sympathetic drive is gone and you come down again, crashes to your actual blood pressure. So propofol should be in the least is in the bottom of the list. Even if you want to use it, then the dose should be reduced to 10 or 20% which will work and usually works in those patients who are crashing. So I think we have covered the induction agents. So ketamine, very good agent. The only downside was that there is a chance that people think that there could be raised ICP or raised intraocular pressure, but that's not the case. The literature is very vague, but in clinical scenario, it doesn't cause this. Etomidate don't use in sepsis because you never know how much amount of adrenal suppression it will cause. Hydrocortisone, how much work or not work. Third is your benzodiazepine, which is midazolam. It takes time to act. Also, it causes a fall in the systolic blood pressure. So, if you ran out of all the both the above medications, then you can prefer. And the fourth is propofol, which should be used in if a patient's blood pressure is good and you want to intubate, like in cerebrovascular accident patient, BP is running 150, 200, something like that, we can prefer propofol in those particular situations. So coming now agents, we can discuss a little bit about condition specific agents which prefer. We'll just enumerate the condition, we can just point out which agents we'll prefer. So the first is in a patients of head injury patients, because it's very very important that you properly sedate and knock down the patient, because there should not be any cough or something like that during intubating such patients, because it will cause raised ICP and there is chances of brain herniation. So in head injury patients, which agent will you prefer?
I would still go with ketamine. If there's anyone who is cautious, or if your neurosurgical colleagues still believe that literature, because sometimes they'll ask what induction agents use, then use etomidate. I don't see any harm with that. The literature, we should talk a little bit about lidocaine pre-induction, because that used to be something that was thought to be protective for people with head injuries and intracranial pressure. That doesn't seem to be very helpful to it. And also, you need to give it 3 minutes before you give your sedative agents. So if we're talking about rapid sequence intubation, you don't have the time to give a pre-induction agent. There is some small evidence that using fentanyl pre-induction might be protective for that spike in increased intracranial pressure. As you're going to hit the vallecula, there may be some increase in ICP. Very poor literature, but I might give that for the head injured patient. I might give them fentanyl in addition to my induction agent. But again, that has to be given 3 minutes before you push your etomidate or your ketamine.
Okay, so still ketamine and etomidate are the choice in head injury patient. Along with your fentanyl, you can use in this. Then obviously, if those are not available in very rare case scenario, which are usually there in the hospitals, you can think of propofol. Now the second is status epilepticus. I would say is again the same condition, or there is something differ in this. If the patient is status
I would
epilepticus,
say, yeah,
sorry.
I would say the same thing. And in fact, there's some there's some literature that's
Mm,
suggesting that ketamine is also a very good anti-epileptic medication.
mm,
So for me, that's even more evidence for me to use ketamine as my induction agent
mm.
for intubation for the person in status epilepticus.
Okay, so that's good. And just have a question from this Intellect Medicos, Dr. Chirag, because we were discussing ketamine and propofol. So his question is, he whenever he was used to be in the ICU, he used a combination of propofol and ketamine to avoid hemodynamic instability. Is this ketofol is a good combination?
I don't think so. I think people were very excited about it when it first came out, because what they thought was, with ketamine, you're getting the rapid dissociation. So that's good because the person's going to be amnestic to the event. And you're going to get some hypertension with ketamine. And the propofol, it causes hypotension and it's rapidly acting. So the two are going to counteract each other. And then they came up with this great name, Ketofol.
Mm,
And I think everyone just likes saying the word Ketofol.
mm.
And the truth is that the data doesn't really show that either one agent or the other is better. So for me, I'm a very simple person and I just want to do things simply and quickly for my patients. I just stick with one agent, and for me, it's ketamine, because again, I have not seen any of the other side effects that Ketofol was trying to prevent.
Thank you for clarifying this very very important question. I forgot to put this thing in my list of the question, but this is very very important question which many of the people who are listening to this right now have in mind, whether we can use ketofol because it was marketed very well enough. So again, Dr. Haney has given a very good, I would say, a one-liner to you all that keep it simple. The more less number of drugs, the less number of things you need to be worry about. You can manage them. If two, three combinations are used, then you have to manage all those in different scenarios. So we were discussing the disease-specific condition, means condition. We have covered head injury, we had covered status epilepticus. Then there is a reactive airway disease where the patient is struggling, there is a bronchospasm, or there is a COPD patients or severe asthmatic patients in which we want to ventilate. Which agent?
Ankur, you're going to make me sound like a ketamine commercial here. But for this disease specific indication, for me, it's ketamine again, because something that we don't talk about is that ketamine has bronchodilatory
Highlighter.
properties, right? So
Yeah.
at doses of zero point 0.3 milligrams to zero point 0.5 milligrams for the person who you see with asthma, you might give that person before you decide to intubate that bronchodilatory dose. So if I'm going to intubate somebody with reactive airway disease, I'm going to want to use that as my drug. Propofol does have bronchodilatory properties as well, but we have already discussed the limitations with propofol. Just keep it simple and go with ketamine.
So we have
And
one.
I don't own any companies that make ketamine. I don't have any stock in ketamine. Just I want to say that clear. It's just to me a
You,
very superior
I
drug.
am telling you, you are making things so simple for everyone to understand that lot of doubts on this podcast or live stream, whatever you could say, many of the doubts will be cleared to many people who are listening. Obviously, this will be available later on also to view, and I'm sure this will give a lot of clarity about various drugs, and they will come too much confident. So just now, like you said, we have one comment from Russia also. We used in Russia, but also I wouldn't say that we have been practicing long to publish any study. It was regarding ketofol. It was regarding ketofol. So that's the thing.
Yeah.
Now, for reactive airway disease, ketamine, because it has a bronchodilatory properties also, and now, now very very important for cardiac ICU patients, in cardiovascular patients, MI with shock, CCF with shock, which agent we should prefer?
I'll keep it unbiased here because again I think ketamine is a very good agent in shorter doses, but again etomidate would be a fantastic drug to use for these patients as well. So I see them as very equal when it comes to this disease entity.
Okay, so ketomidate we were not using because of the adrenal insufficiency, which was specifically very becomes very challenging one in septic patients. But in
Mhm.
cardiovascular patients, you can use etomidate, which is a very good drug. So I think ketamine and etomidate are the two drugs which you need to be very familiar. Go and read about it, the doses, whether you need to reduce the doses. Dr. Hani has also told the doses. Regarding etomidate, can you recommend or suggest the dose which needs to be used? Ketamine, we have listened to zero point 0.5 to 1 milligram per kg body weight. Etomidate, how
Yeah,
much?
point yeah point zero point 0.3 milligrams per kilogram is your dose.
Zero point 0.3 milligram. So in shock, I think in shock, obviously this ketamine will come in handy. Etomidate will be out because of this adrenal insufficiency patient. Except in cardiovascular patients, etomidate is a little bit preferred. So I think now we have covered the induction agents. One question is there. I would like to take it at this stage because we are moving to neuromuscular blocker. Somebody has asked. I just remember. I think they were asking about the barbiturates thing. Sorry, just a second. Ah,
Sure.
yeah, sodium thiopentone as inducing agent in CNS cases. I never used it as an induction agent, but any say on this because they're thinking of
I've seen
barbiturates.
I used to work at one of the largest trauma centers in the states, and they saw a lot of head injured patients. And there were a few anesthesiologists who did the airways, and they like to use that as well. Very vasodilatory, causes a lot of hypotension. And in fact, when I asked the anesthesiologist about that, I said, why do you use that? I know about the neuroprotective effects of it, but it causes so much hypotension. and they would always take out of their pocket, they take out neosynephrine, and they say, I have the antidote for hypotension. And we would have a laugh, a chuckle. But in my opinion, and I have no studies to show you this,
Mm.
I cannot think physiologically how it's beneficial for a patient, especially a head injured patient, for you to have normotension, hypotension, hypertension, normotension. For the injured brain, I cannot see how that's physiologically beneficial. If I were intubating a person, I would want constant cerebral perfusion pressure the entire time without swings. So that's my answer on the sodium thiopental.
Okay, so I'm seeing a lot of comments in the section, but I want to tell you all those who are listening, we are discussing the induction agent during RSI. We are not discussing the maintenance agents after intubation. So a lot of things will not be able to cover in this session, like dexmedetomidate they have told. We are only discussing the induction agents while you are intubating a hemodynamically unstable patients. So we have discussed four drugs. One is ketamine, etomidate, your midazolam, and then propofol. So we have discussed all the pros and cons of this. Now we are moving section to neuromuscular blockers. I think a list a bit simple, but you need to know why we are using it, what is the significance, what are the contraindications, or where you need to prefer one. So the first neuromuscular blocker, uh, first of all, why it is necessary, why you need to have a neuromuscular blocker along with this induction agent in RSI.
So, so when you're doing rapid sequence intubation, it's a two-step process. You want sedation and hypnosis, and then you want the ability to cause neuromuscular blockade so that the airway anatomy is easier to manipulate, so the person's not breathing spontaneously, so you're not triggering a cough reflex when you or a gag when you're doing your laryngoscopy or advancement of the tube. So using paralysis allows you to have very good conditions in that very brief amount of time that we have to intubate. That's why we like to use paralytics. But I have to give you a disclaimer that I don't hear many people talking about. If you are going to do paralytics and paralyze your patients, you must know how to do a cricothyroidotomy. You must, for this one simple reason. There are cases where you cannot intubate your patients, but you also cannot ventilate your patients. Meaning, if you can't pass the tube on the first pass, typically what do? You'll take a mask and a bag and you'll oxygenate and ventilate your patients. But if your patient has an airway obstruction, angioedema, a tumor on the larynx, a burn where there's edema, if you cannot intubate and you also cannot ventilate that patient, and your patient is now paralyzed, if you don't know how to do a cricothyroidotomy, which is making an incision in the cricothyroid membrane and putting an airway into the neck, if you don't know how to do that, your patient can die. And so you must know how to do that procedure if you're going to push a paralytic medication, because if you cannot ventilate that patient, that paralysis is going to last for too long, 15 minutes or beyond, and that person will become hypoxemic and die. So I just have to say that disclaimer.
Very, very, very important. I cannot stress this more enough that once you are using an neuromuscular blockade agent or paralytic agent, you must be prepared for a difficult scenario where you can't oxygenate, can't ventilate like condition, and you should know this technique. I have seen the short on critical care now channel regarding this, and it was very, very striking. The way you emphasize in those 60 seconds is really an eye opener for everyone. So everybody who is listening, go and check how to do a cricket thyroidectomy. There are mannequins, and it's not a tough technique to go. Even in the ICU channel, there is a video where we have shown on the mannequin to do that. So with that said, neuromuscular blockade agents are required because they facilitate to manipulate the airway anatomy because of the stiffness or something like that. So it makes the success rate of the first pass tube very, very, I would say, helpful. So now the first agent, which I think everybody must be knowing, that succinylcholine. How is it? Or I would rather ask you, what are your choices of NMB agents which you would like to discuss now?
I like something that lasts a long time. The reason why is because that situation where you're going to do the airway, and if you take a look and it's a difficult airway, someone else is going to take a look, then someone else is going to take a look in between bagging your patients. I don't want a situation. If I've made the decision to do a rapid sequence intubation, I've made the decision that this person needs an airway. This person needs to be on the ventilator. I've often heard people say they like to use succinylcholine because if I can't pass the tube, then what we'll do is we'll just wait a little bit, the patient will wake up, and then we'll think about what we'll do next. This is not the reality in the ICU or the ER. This is the decision in the OR suite. If they decide they can't pass the tube, they'll do the case tomorrow. Our person in respiratory distress from ARDS or sepsis or whatever the reason is, that person needs to be intubated once you make that decision. So I want an agent that's going to last me the duration of my attempts. And so I prefer to use a longer acting agent. I prefer to use something like rocuronium because it's fast acting and it lasts a long time, so that for the duration of my looks, it'll be okay. Now, there's some more recent evidence that has come out that says that there's a little bit more awareness for patients when we're using our paralytic agent. So the paralysis lasts a long time, 45 minutes to an hour. But if we're not careful about our sedation, once that sedation wears off, now the patients are awake, but they're paralyzed. And there's some pretty distressing literature of what people remember about this experience. So I'll stop there because I know there's some things we have to go into nuances. But for me, that's the reason why I want a longer acting agent.
So the point here is the paralytic agent should be fast enough, it should act fast, and it should remain, contrary to the belief that it should wean off very early, it should remain, keep the effect a little bit longer, because the point Dr. Haney made, that it's not an OT environment. You cannot postpone the case tomorrow. You need to get intubated right now. And if you are not able to do, your colleague will do. In while if the patient gets, if the effect is wean off, then it's again make things very difficult. And not only airway, hemodynamics will also change during this process, and there is a trauma also during this phase. So first, we'll finish up the only agent which is there in depolarizing neuromuscular blocker is succinylcholine, because lot of people ask regarding this agent whether we should use it in, not in the OT but in the ICU environment, how frequently we should we even use it in this, because there are lot of information which is not actually available when a crashing patient comes to ER or the intensive care.
The biggest concern that we have is about the potassium level. So if we have a person who's coming from the outside and we have to intubate them and we don't have any lab tests here, we know that succinylcholine can increase your potassium level anywhere from 0.5 to 1 milliequivalent. So that could be dangerous for the person. You don't want to put them into an arrhythmia. But for everyone else in the hospital, we should have access to their most recent labs. It's unlikely that that person who had labs in the morning, by the evening, they're going to be hyperkalemic and you're going to make them worse. So that's my take on that. There are some subtle, let me start over again. When you look at big trials that have looked at succinylcholine and rocuronium, because this is one of those debates, like should you use normal saline or lactated Rainers, people love to argue succinylcholine and rocuronium. Let me start off by saying that in all the studies that have been shown, in perfect conditions where there is no potassium issues, the outcomes are the same between those two agents. So you really can pick one agent or the other. The nerds like me who like to debate this stuff will say that the downsides to using succinylcholine is its short duration of action when I'm doing an emergent airway, and then the defasciculations that happen with patients. So as they're defasciculating, they're consuming more oxygen for that person, and I believe that could lead to more rapid desaturations for that period where the person is apneic and I want to intubate. But I don't have the data to say that rocuronium is superior. It's only that very nuanced type stuff that we could talk about if you like, or move on if it's too much for your audience.
No, no, no. We can talk about. There is not an issue. Everybody is fair enough. We have time. Actually, we decided around 1 hour to 70 minutes. We still have time. We can cover this.
Cool. Nice.
So,
So
yes,
please.
please. So regarding succinylcholine, which we were discussing, that some labs are usually available at the time, but the point which is very important is it's a depolarizing neuromuscular blockade. So it depolarizes all the muscles, consumes the oxygenation, and the patient is not in a very good shape at that moment. So technically, it's not very helpful for this patient at this stage. What I can get from Dr. Hani was saying. So will pre-oxygenation will help in this? Again, this is a question which is put up. Will if you pre-oxygenate, but 3-4 minutes pre-oxygenation is not usually the time you get in a crashing patient.
Yeah, there's a lot of nuanced stuff there as well, because remember, if you have a patient, let's say, that has, we'll go with ARDS.
Mm.
So that person with ARDS already has a lot of derecruited lungs and
Mm.
lungs that aren't participating in gas exchange. So you can pre-oxygenate the good alveoli. But when I go in to intubate my patient and they're apneic, I want there to be as much oxygenation as
Mm.
possible. So if I could pick an agent that doesn't consume oxygen for my patients, I'm going to pick that agent. So there are a few instances where I will prefer to use succinylcholine, but I presume we're going to get to those as we move on.
Okay, so regarding succinylcholine, not a very means still it because it's used. You can use rocuronium, which is a non-depolarizing, and it's a depolarizing. You can use succinylcholine, but still it is not one of the ideal agent which we are preferring in the scenario which we are doing this intubation. So coming to the non-depolarizing agents, and obviously the one which is used is your rocuronium because of the fast acting effect of rocuronium. So your say on this, Dr. Hani?
That's the agent that I prefer to use, except in a few clinical conditions. And I'll just say them now. Unless I need my neuro exam back quickly, so if it's a person who's in status epilepticus, I need to know if they're still seizing. The worst thing that would happen is if the person is seizing and then I paralyze them for an hour, and then when the paralysis wears off, they're still seizing. That would be very bad. Or in the person who's a neuro patient who I need an exam on. For every other case, I think rocuronium is fine. I don't know if it's available, but there's a drug called Sugamedix, which is a reverser of the rocuronium. If you need your neuroexam back and you have that, it's a very expensive drug. Then you could use that as well. But for all things, again, for me, rocuronium checks all the boxes for my patients. But if you're going to use rocuronium, you have to be very, very, very conscious of the fact that sedation must go up for your patient. As soon as you're done passing the tube, the nurse has to be hanging your continuous infusion agent. And I'll go on a little bit of a tangent here, but it's very important for people to make this part of their practice. Whatever drug you're calling for, ketamine, etomidate, rocuronium, succinylcholine, you must also ask your nurses to bring in the medications that they're going to be using after intubation. The propofol infusion, the dexmedetomidine, the fentanyl. Because if you do the intubation and say, okay, now I need you to go get the propofol and the fentanyl. Now the nurse must leave the room, go to the medication, bring it back, set it up on the tower. You could be talking about 10 minutes, and that patient is aware if you used rocuronium for 10 minutes, and that's very uncomfortable. So be smart when you're calling for your induction medications. Also call for your post-sedation medications. Have everything in the pumps and in the room so that after you pass the tube, I look at the nurse and say, please start the propofol and the fentanyl now so that there won't be any awareness for my patient.
Very, very, very important. I think this is a treasure talk which you are providing to all members who are listening. It's something you are making it so simple, so logical, so easy to understand that we are going to love it. I'm telling you. We can have
Thank you.
some, although this long video will be available there, but some snippets we can share on your channel and our channel also, because these are the golden words which you are providing. So
Thank you.
what Dr. Hani said, that whenever you use a rocuronium, why it is preferred, because it acts very fast, and but the effect can remain a longer period of time. So you should be very cautious in using your status epilepticus patient or the patient who is having seizure activity. You will not be knowing that he is in a convulsive state, and because patient is paralyzed, the seizures activity is still going. So be very very cautious. And as a practice, just want to tell you, in a seizure patient, we avoid any this paralytic agents in our patients, because we always want what's going on with the patient. Secondly, whenever you are intubating a such patient or giving a paralytic agent, make sure the maintenance infusions are ready, made ready before you are intubating this patient, because those 5-10 minutes after intubating and then starting the infusion can be crucial. It may can patient can get awake, though it's because paralyzed, it may not be able to communicate, but have some sort of awareness that what's going on, and this can be a very traumatic experience to the patient in the future. So I think
Can I add one? May I
uh,
add one more thing?
yeah, sure, sure.
Because I think it fits in nicely here. And we're talking about, to me, we talk about critical care. We talk it has to be simple. And so for me, I need frameworks and I need packages of things that I'm doing. So we talked about when you decide to intubate, calling for the drugs that you're going to do. We talked about also asking for the medications that you're going to be using after for your analgesia and sedation. The one thing we didn't discuss that I want people to remember is when you prepare to intubate and make the decision to intubate, you should also be asking for vasopressors to be brought into the room and put on the pumps. Because even though I'm a big fan of, I'm not even going to say it, I've said it too many times already, even that medication can cause hypotension. And I don't want the person to be hypotensive and then ask the nurse, can you go bring in the norepinephrine into the room? Because again, that takes time and then you just have hypotension. So as part of my pre-intubation package, sedation, paralytic, post-intubation analgesia and sedation, I'm also asking for a continuous infusion to be brought into the room and to be put up on the pumps. Now, I don't know the price of norepinephrine in India, but in the United States, it's pennies. So for me, if the nurse brings it in and hooks it up and we don't wind up using it, it can be wasted. It's okay. I want to be sensitive to people out there because I don't want to say that we're wasteful of medications, but the mortality that will happen if I have hypotension and I don't have that medication there will be a much higher cost for the healthcare system and the family of that person who becomes injured from that, that I'm okay to waste a little bit of money in preparation for this very, very high risk procedure. So I just wanted to add that little point into the whole package, because when you go to intubate, it's a mindset of everything that you need to bring into the room with you for the entire procedure.
Very very crucial point. I think this is one of the point which is usually missed during this whole discussion, that you need this agent, this paralytic agent, you need your continuous sedation. But almost everyone, I think 100% of the audience which is working in the intensive care ED, they must have seen the fall in the blood pressure, and then the staff rushing for bring the noradrenaline or bring something to bring the up. So it's noradrenaline is still cheaper here also. So you can make an infusion and then start. If you don't require, that's fine enough. But if the patient crashes, then the cost will be too high, like that. So adding to here this point, if suppose noradrenaline is not there and if we want to push some bolus to bring the pressure up, will phenylephrine is preferred or some other agent we need to push it?
I don't have any evidence for what I'm about to say, but a common practice that we'll use is something called push-to vasopressors. And those come in 2, maybe 3 varieties for us here in the States. The first one that is traditionally used is phenylephrine. And phenylephrine is a pure alpha agonist. And what that means is if you have vasodilatation peripherally, well, now your alpha vasoconstriction can cause there to be better perfusion. Theoretically, no data, but theoretically, if you have somebody who's sick and we presume that their left ventricle is also not performing optimally, maybe there's some cardiac depression, now you put afterload on a very sick heart, you could potentially increase the work on that left ventricle. So there could be some theoretical downsides to using phenylephrine. So for me, a better agent is to use push dose epinephrine. And because epinephrine has alpha agonism, so it gets you that afterload, but it also has beta properties, so you get inotropy. And theoretically, again, it's all theoretical, I now have a balanced agent that if I increase afterload, I'm also increasing the squeeze. And so for me, that would be a better push-dose vasopressor. There are people who can use Levophed or norepinephrine as that, but for me, epinephrine is easy to mix and it's easy for everyone to understand.
Okay, so for push dose drug, epinephrine is the first one, followed by if you can have phenylephrine if it's available. Now times I have just gone through that it is coming in the pre-filled syringes, the push dose for such cases.
Yeah.
Now 1 month back I just came across that. So anything you would like to add regarding vacuronium and etracurium and pancuronium, just because the audience had the questions regarding that whether they should be used, because etracurium is something which they use during induction, not vacuronium pancuronium. Anything about that which you like to add?
It doesn't make sense for me to use that if you have the other agents available.
Mm.
I want to be kind and I want to be sensitive to people because I know not everyone has access to the things that we're talking about. But when we're talking about agents to use for paralysis, they have to work very quickly. And so if you're waiting on a medication that's going to cause some partial paralysis and now your person's breathing a little bit less and now you're waiting minutes and minutes and minutes, that patient is going to start to deoxygenate. They're also going to stop ventilating and that CO2 is going to start building up. So you need something that really works fast for your patients. And I'll put this in here because I'm not sure if we're going to talk about doses, but let me just say briefly here, when we're talking about succinylcholine or rocuronium, in contrast to what we said about the sedative hypnotics, where we're reducing the doses to worry about hypotension, in these agents, you want to go as maximum as possible when you're pushing your medications. And the reason why is because all of the sedative hypnotics, the ketamine, the etomidate, propofol, Versed, they all are lipophilic. They all work in the brain. So on the first pass, you're going to get to maximal effect for your sedation. With the paralytics, they all work on skeletal muscles peripherally. They're working on your diaphragm, which is a skeletal muscle, your intercostal muscles. And so if you have a person who's in shock, remember, those tissues may not be perfused as well. And so it may take multiple passes for you to get your effect, your maximal effect of paralytic. So for that reason, it's important that you go to maximum doses for your paralytic drug because you want it to work as quick as possible to maximum effect. And there's really no harm. You can't overdose a paralytic. The person may be paralyzed a little bit longer, but there's no hypotension that happens. There's no true side effect that happens with giving more. So you can go on the higher end of your normal dose, but don't underdose your paralytics when you're doing rapid sequence intubation.
Very, very important point. Again, just a contrast between your induction agent in sedatives versus your paralytic agents. In sedative agents, you need to decrease the doses because in first pass they reach the brain very fast and act very quickly. So the dose required is less. While in peripherally in the muscle, in shock, the paralytic agent needs to be act in the maximum doses, so the dose is little bit increased. So because we are discussing the doses, so can we discuss the doses of two drugs? One is rocuronium and the other one is succinylcholine. If you want to share the rocuronium dose which should be used.
Yeah, the doses that are often quoted are between 1 and 1.5. I like to get to go to the 1.5 dose. I hear people talking about just saying multiply by 2, double the rocuronium, so you give 2. I don't recommend that, but 1.5 should be just fine. And
And regard
succinylcholine, mhm. Yeah,
succinylcholine.
succinylcholine, yeah, 1.2 to 1.5 is also the doses that are recommended. So it's pretty easy to remember.
So we have covered vacuronium, pancuronium, etracurium not preferred because they are slow acting, takes time to act. So rocuronium is the thing which is used in most of the scenario. They should be used. Any reversal agent you have told already, Sudamedics. I think you have mentioned in the thing. Any reversal agent which should be kept with the paralytic agent
That's
in,
the only one that
in
that
that.
that we that's available for that. So and it's very expensive. And I'll be honest with you, I don't really have access to it in my setting. It's more for the operating room. They reserve it there.
Okay.
But as it
So
gets cheaper, I hope to use it.
so. With that, I have one questions which is because I have jotted down in my list. I am asking Any special preference for paralytic agents in myasthenia or GBS, some sort of condition?
Hmm. Yeah, again, I'm just going to be using rocuronium, to be
Okay,
honest with
that's
you,
that
for
thing.
most of these people. Yeah, yeah.
So now we have discussed both the sedative agents and the paralytic agents, and ketamine etomidate takes the top chart. Rocuronium straightforward in as a paralytic agents. Then we have discussed what are the pros and cons of it. So you can, when this going is going to be updated on the channel, you can go revise and go backward and forward to listen things about each and everyone. Sorry, some noise from the behind. Now we'll be taking some questions from the this chat comments which are posted here, so that if anything which we have missed, we can cover up. So the one which is there is, I found is very nice. What about hypovolemia needs to be corrected before ventilating the patient? This is very valid
Oh.
point. If hypovolemia should be corrected to avoid hemodynamic instability.
Yeah, so this is a great point. We should probably talk about the bigger topic, which we didn't get into, is the concept of resuscitate before you intubate concept. We talked about the rapid sequence intubation, but we should be talking about the resuscitate before you intubate, meaning you have the person who is very sick in front of you and you're going to make the decision to intubate them. We talked about giving them medications like Etomidate or Ketamine that's going to take away their sympathetic drive. They're going to drop their heart rate, they're going to drop their blood pressure. What happens when you go to intubate somebody? You start bagging that patient. When you bag that patient, you're causing decreased venous return, and so there's decreased flow into the heart. That causes hypotension. And also, when the person's apneic, that person is not ventilating CO2, and that leads to a worsening of your acidosis in a person who might already have been acidotic because they're critically ill, and that acidosis causes vasodilation and cardiac depression. So that active rapid sequence intubation that we do for our patients is a very dangerous procedure because we are putting this person at risk of death. And so that is why it's very important that we need to resuscitate that patient before we intubate them. So giving the person who's hypovolemic volume is very essential. It turns out that we used to think that just give everybody who we're going to intubate a liter of fluid and it'll be helpful. That data doesn't show to be useful. So for not every patient who we're going to intubate, we should give them fluid. But if you know the person's hypovolemic, give them volume first. I'll also say an important thing to do before intubation is to make sure that you have good monitoring. If you have the ability to get an arterial line in your patient, because I know not everyone has access to it, but if you do have access to arterial line, try to get an arterial line in your patient before you intubate them, because then you can know second by second what the person's hemodynamics is while you're going to intubate them. If you don't have an arterial line, be sure that you cycle the cuff every 1 to 2 minutes. Cycle the blood pressure every 1 to 2 minutes so you constantly get feedback on the person's hemodynamics as you're getting ready to intubate this person. And then again, if the fluid is not helping, start vasopressors early on your patient. Make sure you get that blood pressure adequate, because I have never in my 13-year career now, I've never seen one person who I intubate whose blood pressure went up as a result of intubation. It either stayed the same, and more times than not, it dropped. Because 1 in 4 patients who we intubate, 1 in 4, 25% of people who we intubate who are critically ill will experience some level of hypotension. So I know I said a lot and I apologize, but it's a really important thing that when you go into intubation, you have to resuscitate that person before you put them into the situation where they're getting hypotensive, bradycardic, and acidotic.
I can't thank you enough for explaining it so beautifully. And I have gone through all the comments in the channel till date, and you almost everything you have covered in the session. So we'll be taking one last question in the end. There is a case scenario which one Bhupendra has added, just for testing us, I think, which agents to be.
Yeah.
So he's saying that a middle-aged man sedative overdose, GCS means sedative overdose is there. The GCS stand difficult airway, respiratory acidosis. What are the agents in this sedative overdose patient?
So let me be clear. The person maybe is had a benzodiazepine overdose or an
I
alcohol
think.
overdose. Is that the
Uh,
question?
uh, I think.
So the agents for me don't change. I hear sometimes people saying, "Well, this person is, they're already altered, so just push the paralytic medication and then let's go to intubate them." I don't. I cannot get inside this person's brain who we're looking and going to intubate, so I don't know if they have any awareness. So for me, I like to make them not aware. I like to err on the side of caution. I give them the medications, and we already talked about the medications to give, and I paralyze them and I intubate them. That's my. Now, if I know somebody comes in and they're completely apneic when they come in and they're not breathing because they have an opioid overdose, in those cases, I might put an LMA into that person, reverse them, try to wake them up if I can, and then, go from there. But these are very nuanced cases. But the bottom line for this is that I don't ever assume that the person in front of me is not aware, because I can never tell if the person is aware. I'm sure from your experience and your reading, that there are patients in the ICU who look, for all intents and purposes, to be completely amnestic and sedated. And when they wake up, they remember the conversations that were happening around
Fair
them,
point.
which tells me that I can never assume anything about my patients in front of me. Just treat them well, make sure they're comfortable, and they can tolerate that procedure.
So beautifully explained. So that I think that we are completing this on time. It's a 1 hour session, and I think the audience will not stop here. I think you need to spare time a little bit. I request you to spare time in the future also for some topic. I think the airway management in a crashing patient, resuscitation, a whole lot of a different topic. We can discuss that. We'll chat about this later on. But I'm really, really thankful from on behalf of all the audience which is viewing right now from India or from abroad. There are many nations which are connected now. And anything you would like to tell them as a message before ending? So, so,
No, I,
so
I,
thankful.
yeah, no, I'm very thankful that you all had me on. I feel as though, even though we work in different continents, we all have the same vision and the same goal.
Mm,
And that is to make sure that when we meet a patient who
mm.
is on their worst day, or we meet a family that's on their worst day, we provide them with the very, very best care, and we try to be as kind and humble as possible. And I've never met you in person, but I see the work you do and I can feel your energy and your soul. I know you do the same thing too. So for all the trainees out there, just remember, critical care, resuscitation, it's all very, very hard work that you do, but it's very important work. You're meeting the person on the worst day of their life, and you are the person that's going to get them through this. And you have an amazing, incredible responsibility and a job to do. So thank you all for what you do every day. And I wanted to give a gift to your audience because they're so amazing and they've been here today. What I'll do is I'm going to give you a link that you can post in the channel here, and they can go to the link and they can download one of the conferences that we've done with all the great speakers that were at the conference, and then they can watch it and enjoy. And it talks a lot about the things that we spoke about in addition to other critical care topics. It's 3 days of a conference that they can watch at their leisure. So I'll send you
So,
the link later.
so nice. It's a bonus. I'm telling to all the audience, I was also not knowing this, that there is a gift from Dr. Haney or Critical Care now to our team. But thanks a lot, and hope we'll meet in person very soon. Somewhere or other, we'll encounter each other. And
I hope so.
on behalf of you, I can say to my audience that, or your audience also, which is listening from Critical Care now, that in future we'll also try to have different sort of conversation regarding this. Thank you, and I'll post that link by tomorrow or maybe in some hours in the description of this video. Thank you and namaste, and many many thanks.
Thank you for
We
having me
can
today. And thank you all for watching.
we'll end here. Thank you.
Thank you.